Hello, and welcome to our summary of your midterm presentations. I wanted to say, first of all, great job on finding some assessments and great job really pulling apart the parts that, or pulling out the parts that are most meaningful from both the design perspective, but also the statistical analysis and also clinical implications. I love that so many of you, when trying to make sort of this clinical decision of what's the utility of this test, also pulled in some articles from, about this test from other sources to sort of make that decision. I love that everyone's kind of in this position of just like, well, I can't make a decision based on just this one article. I probably need to look at more. That's perfect. That's exactly what you should be doing. So one of the first tests that or assessments that we looked at was the athletic ability assessment. So that was posted by one of your classmates. This is a really great assessment tool looking at quality of movement. So very has a lot of similarities to the FMS that we've covered so far. Some of the disadvantages is that it hasn't there's really only one article on it, and so it doesn't really have any predictive validity in terms of predicting injury or anything of that nature. It also, because there's only one article on it so far, I don't know that we have evidence that shows that we can change the scores that people have. So I think clinically, most of us are probably like, well, yeah, obviously it can change. If it doesn't, we're all out of jobs, right? Like if we can't change those things, we're doing something wrong. So I think clinically, I think it's pretty fair to think that we could improve those things, but empirically, we can't necessarily support that just yet. I also have sort of a critique from the perspective of the idea is that it's supposed to be, in my eyes, sort of a progression from the FMS where we're now putting people under load. And I love that idea. But I do question, a plank as kind of categorizing that as a highly complex movement. I mean, if you really think about how the core functions in daily activities, but also sport and recreation, it's not in this single plane static hold. It's much more dynamic than that. And so that's my biggest critique as far as the exercise selection for that assessment is it doesn't. I don't think it really truly captures the high complexity movement that I think it wants to. So I think of all the things that I saw this week. That one shows the greatest promise. I'm kind of looking forward to seeing where that goes in the future. The rest of the test sort of looked at identifying, basically valgus collapse. So we did that with sort of the drop vertical jump, sort of step down or single leg squat test. There's a different variety, but basically all we're looking at, biomechanics and kinematics of the knee during loading tasks. Pretty much what we see is that we can identify those things pretty reliably, but it doesn't necessarily tell us why. So what we saw was that in one of the articles that hip strength didn't have any relationship to having these sort of faulty kinematics. So it's like, okay, so we know that this sort of loaded eccentric position of the knee is not great, but we don't really know why. So a lot of the tests also utilize things like cameras to help capture some of these faulty movements in the assessment. And one of the questions that I posed was do you really think clinicians will do that? And I understand with the advances in iPhones and things like that, it's really easy to do those things now too. But I also kind of think of it from a clinical utility perspective of how much time invested is how much time investment is really happening when you're doing these things, and is it worth it? So even if you're only spending, say 5 minutes doing the movement and kind of looking at the video, for a lot of clinicians, you only get 30 minutes with a patient. And sometimes those 30 minutes are overlapped with other patients. I'm really fortunate to work in a clinic that it's not like that. And so if I want 45 minutes or an hour with a patient, I can usually get it. But that's not the case for a lot of clinicians. Sometimes, like I said, it's 30 minutes and you're overlapped with other patients in that 30-minute time frame. And so when I think about spending 10 or 15% of my session, doing an assessment that doesn't provide predictive utility and doesn't direct my clinical decision making regarding care or return to sport, then it's like, well, what value does it provide? So that was some of the takeaways from people was that, I see the value in the test. Well, what is it? I certainly agree that getting a good sense of how people move during a functional task is good. I absolutely believe that. I also think that if I'm going to spend time doing something like that, I want something in return, and I need to have some kind of tangible answer as far as like what it gives me. I also sort of pose the question of just like, why do we care about valgus collapse? I mean, we saw very few studies for a very long time, especially prospective studies regarding injury prediction and valgus collapse, and we just didn't really see much of a relationship. But it's sort of this traditionally held belief that this is bad, and more recently we've seen some more prospective studies examining this specific thing, this valgus collapse and injury prediction, and it doesn't. It's not. There's no relationship there. So let me be clear. I'm not suggesting that valgus collapse is good or that we shouldn't be capturing it. I think it's something that's worth noting. But I also question, why do we continue to care about this when we're seeing fairly consistent results that maybe this isn't where we should be spending our time. Maybe we should be spending our time elsewhere and doing other things. The last thing that I hope people take away from this assignment is that it's really hard to find other assessments that look at movement quality that are reliable, but also direct care or help us make predictions about future performance or injury status. A lot of times we get questions from students, the questions that sometimes feel like accusations, honestly, about, why do we teach the things that we do? Why do we use the FMS and why do we use the Y balance test? And I hope that by searching for these other assessments and comparing them to the things that you have learned in the class, that you realize that this is why we teach the things that we teach. Is there's a body of evidence that supports its use, and certainly it has its faults, particularly with the FMS and its predictive validity that's been called into question certainly over the years. So they're not perfect, and we're not suggesting that you should use any of them in stand alone. But until something comes along that's better, we're going to continue to teach those things because current evidence suggests that this is our best practice and our best tools to help us make those decisions. If you have any questions about the presentations, if you have any questions about anything that we've covered thus far, please reach out to myself or Dr. Matzel. And again, great work on your presentations. We'll talk to you soon. Bye.